Everybody. Hi, Martina. How are you? Um, well, I guess we're a few minutes past. I just had some technical issues there, but thank you very much for joining us, Martina. As the rest of you may or may not know, I suppose you do. It's in the um, in the blurb. Is that we are very fortunate to have Martina Hennessy, who joined us, or who's of course been in the School of Medicine for many years, but has taken on the role of Chief Clinical Academic Officer representing Trinity and the Dublin Midlands Hospital Group in this exciting role. And I guess you've had a couple of months or a little bit of time, Martina, to get your feet under the desk and to begin to think about the role. And you're going to share with us today what your vision, I suppose, and some of the issues that you've been working on. And we have time then for some questions after that. Is that okay, Martina?
Sure. That's
Yeah.
great.
Great. Well, I'll hand over control to you then.
Okay, somebody just said that I think you have to enable the video so that somebody can put I don't know. I've just got a message from somebody there.
Okay.
It says, turn on the camera so I can spotlight you, but I can't turn on the camera because I think you must still have control of it, or Lena has.
Yeah, Lena, I would say yes.
That's great.
Yeah.
Thank you.
Lena's the host, so hopefully she can do that.
There, that's it.
There we go.
That's
Great. Okay. Thanks, Martina.
Thanks
Sorry about that. You were in the dark there for a while, which for you is very unusual.
No, I'm definitely going to get blinds from here on in. Thinking in the dark is a good thing.
Over to you then. Thanks.
Great. Now I'm sharing. Can you see that?
Yep.
Okay, great. Okay, so see if it comes up. That okay? Okay. Very good. So thanks very much, everybody. I'm delighted to be asked. I'm very sorry if you've heard this a few times at this stage. We've done it a couple of times. So if so, apologies. But hopefully it'll remind you a little bit about who we are and what we are exactly as a group. And who am I? And I suppose I'm a clinical pharmacologist and physician. I suppose that's the calling card I'm coming with, and being director of the CRF at St. James's. But before that, associate professor in medical education in the School of Medicine. And really, all of the posts I've had have kind of brought me to the nexus between education and research, and that's where I hope to use. That's the area I hope to use to inform this post. And my calling card really in all of this is service to the academic community and to my communities of practice, really, as a clinician and researcher, and also as an educator. So I've done a few things in my time. I've started off when I came back to Trinity first in the education space, but always keeping my links to the hospital through clinical practice with clinical pharmacology. And then at different times, took up a post as the Associate Dean of Research for the college, and that was very interesting. And I learned a lot then about the front of college, and then gradually moving back to bring front and center the research profile with the directorship of the HRB. Clinical research facility at St. James's, and most recently coming back around again, always twisting around this kind of circle, if you like, coming back to establish the discipline of medical education in the school. And I can tell you one thing that I know about all these things that I've done, and that is that there is no quick win, that everything takes a lot of time and graft and effort in order to get it right. And when you do, and it works occasionally, it's a great feeling to see things progress. So that's me. And then there's this group that we're in, the Dublin Midlands Hospital Group, perhaps to say something about it. There's a lot of academic opportunity in it, I think, and maybe if I just remind you a little bit about it. So the Dublin Midlands Hospital Group is a very big group in the sense it's 6 major hospitals, soon to be joined by a 7th. It crosses over 5 counties. It's got about 2,500 beds in total between its 7 units. And when Mullingar joins the group, the population that it serves will go up to about 1 million, with an operating budget of around about 1 billion. So it's a very significant group. It's large and diverse, and the metrics speak very well to that. But it's also very complex in that it has a complex history, being a collection of both voluntary, federated, chartered and statutory hospitals. Now, all the groups are big. So beside it, you see CELTA and Ireland East. And CELTA covers 25% of the land mass of the country, and Ireland East has 11 hospitals. They also have huge, complex budgets and lots of patients, but perhaps a little bit less complex, particularly in terms of CELTA in what they do. But the thing is that what to realize is that the Dublin Midlands group delivers the same sort of levels of activity as the largest group, but it does it with a smaller number of hospitals. So that produces some advantages. So what we have is a very complex mix of caseload and casework, and with 24 of the 27 national specialties nested just across within 6 units. So it comprises 2 very big Model 4s, and although they've developed and emerged in very different ways, they have a lot of complementarity in terms of the clinical services they provide. So, for example, you'll see a lot of infectious diseases perhaps on the James's side, but you see far more renal, for example, in Tallaght. So they have a lot of complementarity. And even if you look below that and look at smaller services, like, say, for example, cardiology, there's quite a lot of complementary strengths between Tallaght and James's in terms of what they provide. One emphasizing the interventional, the other emphasizing the inherited cardiac diseases, and heart failure. So there's a lot there to think about. And then on top of that, we have the 2 very highly respected units with the COOM, and we have the emergence of the Children's Hospital will be in this group, and also we have 4 Model 3 hospitals. So that's a huge amount of capacity, really. And it's lucky that we're the same size and mix to be able to maintain quality and access. And the voluntary hospitals that we have in the group, well, they have a degree of agility to act and to be flexible, whereas the statutory hospitals within the group, well, they have the ability to attract the attention of government. So we're soon going to be joined by Mullingar and CHI, and of course CHI will be a group all in its own right, and this will be a great mix for growth as we look outwards. Things, though, to be familiar with this group, we have the exclusives to the right and the inclusives to the left. So everything on the right-hand side can have and has Trinity as its primary academic partner, whereas everything on the left-hand side has got many academic partners. And of course, nursing and pharmacy and the other disciplines within the faculty, they all realize this because we're all negotiating all the time with the hospitals on the left in order to look for clinical placements. So that comes at a bit of a cost, in that, negotiation is just always going to be a fact of life for us, because we're really so close to so many different major university medical schools. So we're going to have to always be in a negotiating position. And this is really what's going to happen when it comes down to clinical placements. We can never disadvantage our other academic partners, but at the same time, we have to find a way to put ourselves in pole position. In addition, the growth patterns of the various units have been a bit unequal in the past, with St. James's somewhat constrained in its ambitions by the emergence of the very wonderful Children's Hospital on its site, whereas others, like Tallaght, have been able to grow more freely and organically over the last number of years. Over time, some of this will balance out, and we expect it to just be fine. So the Dublin Midlands also has the advantage of proximity. So none of the sites are really more than an hour and 10 minutes from each other, or an hour and a half from Dublin. And that has meant a lot in terms of clinical autonomy and access to clinical services between the different hospitals. And what it's done is it's driven up the standards, the clinical standards across the group. It's also conferred advantages for education, for research and innovation that haven't really yet been realised. And it'll be a matter to try and identify where those synergies exist and the structures that need to be unlocked in order to connect them are going to be central to the role of the CAO. That said, I would have to say that these hospitals might as well be 1,000 miles from each other if we cannot actually develop the connectivity between us that we need in order to be able to thrive. And the group is going to benefit greatly from having a very engaged academic partner, because the academic partner will really form the linchpin between the various units. What it does mean is that that proximity in practical terms means that joint and shared positions and appointments are quite realistic, that shared assets are really relatively transferable, and that clustering within the group is achievable. And there is some drive towards clustering, within the group, within the Model 4s, perhaps supporting individual units on either side. So, for example, Tal is supporting Naas and James is supporting Tullamore as they develop. So that's and that's, I think, what's going to be a very nice part of this, is to develop those links between the different units. So the question is, what now are we going to do about the integrated care platform that's suggested through Sláinte Care? This is going to be obviously a national imperative, and it's going to be critically important to the group and to its 1 million patients, and it'll be underpinned financially, we hope, with staff and expertise that we both want and need. So how are we going to actually make the jump from being very hospital centric, and particularly very Model 4 hospital centric, to evolve towards a much more community facing approach in what we do? And how are we going to make the academic work and academic capacities that we bring to the system, how are we going to translate them into the community setting? Well, I'm not quite sure we know yet, because mainly I'm not quite sure we know what that Sláinte Care RHA implementation plan looks like for us, but this is some of the things we do know about it. So the Department of Health and HSE commissioned some work to look at market factors of other countries compared with Ireland when they were just determining how the RHA implementation might look. And what you can see from this is that if you compare us, for example, to somewhere like Sweden over there on the right, we're spending a lot of money. We're certainly spending as much money as our Swedish counterparts, but our health spend as part of our GDP is less. And we don't feel necessarily as if we get the same level of health services in Ireland as might be possible in Sweden. And there are many, many reasons for that, some of which are long beyond what this role or this university can do. But what we do know is that although we have an awful lot of beds, we have roughly the same number of beds per 1,000 of the population, and we don't seem to have enough. So we consistently have a demand that exceeds our capacity for beds. And one way of dealing with that is, I suppose, to transfer some of the care, what care is possible to transfer into the community and move it away from being an overly hospital-centric model. And this is part of the reason why Sláinte Care is coming about the way it is, and why the RHAs are being developed in the way they are. There's an interesting thing in here. If you look at the nurses, the nursing and midwives nurses numbers that we have per head of the per 1,000 of the population, they're actually quite large and quite high, but at the same time, again, we have their if you like, streamed into different pockets, so we don't necessarily have the transdisciplinarity elements in our workforce, either medically or at nursing levels, that perhaps might be warranted by a change towards the community. And so our schools of pharmacy, of nursing, of medicine are going to have to adapt to be more community facing in terms of the education that we provide. So there's a couple of different models for how the RHAs might work, and they may be distributed along existing integrated care areas, which would leave us being called in the new world RHAB, and it's still the same, basically the same number of patients, still around 1 million. There's another option on the table, which is that we line up again as RHAB, but this time against 5 or 6 community health offices. And again, it comes out to roughly the same number, makes us ever so slightly bigger, but it's a similar sort of model, and this has not really been decided yet. What it does look like will be the case is that there will be a regional CEO who will be over the RHA. And there, if you look at the very bottom, you'll see that that person will have some responsibility for clinical and population health, and within clinical and population health for clinical and academic research. And so that's going to be where we intersect, certainly in terms of our academic work and our research work, but not necessarily clearly in terms of the training. That's how we'll interact probably with the strategic management team of the RHA. once that is decided. So there's a lot of things still to be clarified. For example, the role of the voluntary hospitals within the RHA and other partner organisations, that's still to be clarified, as have the associated governance arrangements. We need clarification on the governance for national services versus integrated services versus hospital services, and also on the relationship and arrangements between the RHA functions and the national functions. And how will it all align with the public health model in terms of health protection? Fortunately, Trinity's in a great position here because we do have an Institute of Population Health. And so we're well advanced in terms of that, and also with units like health policy and management. So then we come to the very wonderful Trinity, and what does Trinity bring to the table here? Well, we bring the strength of the academic partner, obviously in the top 200, really worldwide, with the medical school and the nursing schools and pharmacy schools, all really within really acting at the top of their licenses. The metrics are really staggering, but the important thing is that the university really wants to build a sustainable future in health and to graduate people who will meet societal needs, and that's so important for all of us. This is where we all lie, really, along our train tracks, if you like. And on the right is the Trinity East side of us, then moving into the School of Medicine, delivering, as we do, all the health professional degrees, and really being quite the largest provider of healthcare practitioners in the country. And on the left-hand side, you see, as we move out to our hospital partners, St. James's, the Coombe, Tallinn, Naas, out to Midlands in Portlaoise and Tullamore, and then soon to be joined by Mullingar. So we have around about 3,500 students across us, and that is a very significant footprint into the workforce of the future. But more importantly, the workforce within our group is around about 11,000 people. So what you have to see is that simply by producing undergraduates, we could never really do enough. We can't ever close the gap. So we have to be able to operate in the postgraduate space, and very effectively too, in order to create the workforce of the future. So thankfully, one thing we have been doing is we've been delivering interprofessional education for around about a decade together, and that was started as initially an initiative between the faculty and the School of Medicine, then taking in the School of Nursing and Pharmacy, Dentistry, and so on. And we had a long history even before that of the dentists and the nurse and the medics being taught together. So we have a basis on which we can work, but I would say that we possibly haven't pushed that far enough over the last 5 to 6 years, certainly, and we're going to have to perhaps reinvigorate the way we conceive delivering interprofessional education. We also have a lot of capacities within the system. So we work through some 27 or 28 entities really around research institutes like aging and biosciences and population health, translational medicine and cancer. And some of these are transdisciplinary, not all of them. Some of them are rather have too narrow a focus, and perhaps that focus hasn't reached, the relevance of that focus perhaps doesn't always reach into the clinical arena. But there is a lot of connective tissue between our various research programs with things like InfraKids, cross-disciplinary consortia such as the intellectual disability groupings, and lots of educational offerings, and they reflect specific strengths. And throughout all of that, the clinical partners provide the strength and stability to the whole thing to keep the moving parts going, and they give us the scope to extend a great deal further from bench to bedside and to population health. So we're talking about a lot of different opportunities, and we won't be able to do any of it in a vacuum really without addressing some of the challenges underpinning all that. So we have to really frame ourselves in terms of the identity and in terms of our partnerships. So what is this job about anyway? And that's the thing. So this is what it says on the tin anyway in the job description. So and you'll see them all here. So I'm going to take each of them maybe and say a little bit of a word about them. So the first one is developing an integrated approach to innovation, education, training and research for all the healthcare practitioners within the Dublin and Midlands Hospital Group. Now, to me, this is maybe a little bit too initiative, because I think we've been doing this already in pockets, but really now it'll be about developing a more fully realized version of the integration across teaching, research, innovation and education and across the group, but also about focusing the outputs of that into much more into the clinical spaces that we occupy and intend to occupy in the future, so that the transfer of ideas and impact between the university and its clinical partners is enriched, and that the relevance of the academic partner is underlined at all times really in the clinical arena and leveraged very specifically to improve patient outcomes. And there are some good examples of where we get that right. And here's a good example. And I would say the relationship between MISA and TILDA in the clinical side and the research side is a really excellent one, very well articulated here by this particular project, which was EIT Falls project run by Professor Roseanne Kenny, but also run by the whole of the MISA staff, really, I would say. And other good examples of it would be in the CRF, where we have a good relationship between the CRF, St. James's, and now CHI. And that relationship extends just beyond doing research. It extends to sometimes the exchange of staff, the exchange of pharmacy staff, and working together to do things better that can improve patient outcomes. So we have great education and research impact stories from all over the group, but sometimes we don't quite make enough of them. And this is one, for example, from Portlaoise, and it's about the development of educational processes for patients with type 1 diabetes and type 2 diabetes, and about that sort of engaged patient group. So we probably don't do quite enough there, and we may need to do a bit more. So it's really about framing the culture that matters here. It's about identity and partnership, and this role, the aim of the role, will be to connect more dots and develop our joint identity further. And by that, what we want to do is articulate our core values and themes, but use those to secure both internal buy-in within the university, but also external recognition of the quality of the group and of ourselves as a whole. And thereafter, looking for the resources to try and maintain that partnership at a deep level. So the second one is to strengthen the profile of the academic partner to ensure a cohesive and integrated approach to healthcare education. Now, this really has to be around the delivery of the educational mission, which in clinical terms, is not just about the number of graduates that we produce, but also about delivering the workforce of the future. And in this, I think we need to think about expanding our postgraduate horizons, not just offering more, but offering better, and offering more cross-disciplinary offerings. Really, I think it would be important, and maybe integrating insofar as we can with what we offer educationally with what the clinical sites want and need, and making sure that that's a parity of esteem approach that we take to partnership in the delivery of all those offerings. So the workforce of the future is almost entirely team-based. And so I think our courseware, although we have a lot of it and it's of a very high quality, sometimes we don't emphasize the team elements of it, and it may not be integrated enough. So that needs to be more recognizable to the practitioner, but also to the payer. So these are the kind of things, and we would look at things, for example, like critical care and perioperative care. These are areas where, for example, we could see an awful lot of work that we could do and deliver a lot more in terms of the transdisciplinary actions that go on in those particular clinical domains. So then we have the issue of the clinical placement. So it's in these, really, it's about 3 different levels. So at the CCAO level, it's about providing secure tenure, really, and securing academic capacity for our students within the health system. But at the group level, we need to use all of our educational expertise to badge the quality of our learning environment and develop a common notion of what is the standard of a really good clinical learning environment. Locally, the responsibility then will be to provide tools and time for faculty development, so that we have better supervisors and mentors to live up to the badge and provide authentic experiences to our student. So coming from the top down, we'll need a distributed leadership really across the group, and investment in that distributed leadership. And I'm thinking here of things like, the very wonderful clinical practice facilitators that exist in some of the disciplines, but not necessarily, for example, in medicine, but they exist very well in nursing, and trying to ensure that those individuals can practice at the top of their license and in a very mobile way, so that they can look after our students across all the different sites. And we have to be able to learn and share best practice, and to loop that best practice and in educational innovation back around to the top of and so that it can cascade down through the system. So for that, we all need 21st century curricula. And what is a 21st century curricula nowadays? Well, it's something that really doesn't have walls. So the days when we can capture all of our students together in a clinical place, in a lecture theatre, or indeed in a clinical placement, are kind of gone. And I suppose what we have to do is tailor our curricula now to respect the fact that people want choice, and they want a hybrid environment, and they want to be able to use that hybrid environment to their own advantage. I suppose it'll be about learner needs, and getting learners to diagnose their own learning needs and to input into the more personalized learning programs, really. And then we have new aspects of learning that we have to think about, such as our place in the overall world and the sustainability of the healthcare systems that we're providing. And I think I would see data sciences, and we'd also see things like planetary health coming to the fore in the next wave of curricula. So we also have to think about harnessing our mentors and our teachers, and getting people to credentialing people up to the top of their license, so that they can be better supervisors and be better teachers. So it's to some extent top of the list of identities is being a hub for very experienced researchers and clinicians, but also being an incubator for rising stars. So the Dublin Midlands really needs to be the place that provides people with a capacity to flourish. And the examples of this would be things like the academic track for internship and ICAT. But what we need to do, and we've never done previously very much, but we have to do it in a more programmatic way, is to develop the clinical academic career pathways for the future. Not just for medicine, but for nursing and pharmacy, for dentistry. I think this is something we need right across the faculty, and which the group really needs us to pony up with to some extent. We need to develop these the mechanisms to do this, and it's certainly not going to be a one size fits all. It'll be certainly different for each of the disciplines within the university. But important that we start to build a workforce that will take us into the next 20 years, the next 30 years. And we can only really do that by investing in people. It would be also critical to identify, a research enabled workforce. I don't know if you're familiar with this notion from the UK, but it's been very successful, developing 1,000 principal investigators, where you would say, we have to open up the supports and the mechanisms whereby people can do close to patient research, by making sure that we underpin that with good clinical practice training right from the beginning, from induction, and also research integrity training, and leaving people open to explore that aspect of their work and what they can do with that. So then we have to identify research priorities for the Dublin Midlands that are consistent with the strategic priorities of TCD. Now, I think I turn this a little bit on its head and say, what about the capacities of the Dublin Midlands that are not already articulated in the strategic priorities of TCD? So while we're very good at recognizing that cancer is common to both of us, and certain things are common, now children's will be common to both of us, but what about women's health and complex care or population health? We understand all right that aging and intellectual disability, but there are a great many more capacities within the Dublin Midlands Hospital that are not already articulated very strongly in our capacities as our priorities within the university. And I think we possibly need to look a little more at that. Now, there are good examples, such as, for example, the Trinity Cancer Institute and the development and its accreditation as that, and then the addition of the Trinity Academic Cancer Clusters and the radiation oncology clusters, and they've been particularly good. But there's a lot more of that I think we could do, and even these things are not maybe as integrated as they could be. And again, developing the advanced therapies pathway from genomics right through to research to clinical practice requires a much more integrated thinking around things like biobanking and the national genomic strategy, so that the research to clinical service transition becomes much easier. And then in doing that, we could unlock the catalytic power really of the data that we have between the university and our clinical partners. So we now have to elevate all that thinking a little further by considering the links between our academic life and academic general practice, led by Susan Smith and led by the Institute of Population Health, as the hub really to seek out pockets of evidence that tell us whether integrated care will work and how that will feed forward into health policy and management of the future. And it's very important that the Trinity School and the Trinity faculty and the Trinity group does that together, because we really have to inform policy if we're going to make a difference. Of course, we have a group which has a huge population, and across that population, it's culturally and ethnically diverse. It's growing, but we have a higher than average deprivation index, which will manifest its particular health needs, and inclusion will be key. So we have lots of examples of great research, but the two I like best in a way are the one that is about improving outcomes and decision support, and the MDT, living with and beyond disease, very much led by physiotherapy, and the one on the right, multi-HPV, very much led by nursing and the COOM. And these are very good examples of, I think, the kind of research strengths that we haven't built out fully, and we have plenty of capacity left with. Lastly, it'll be about developing relationships with industry to support innovation. And this is maybe where we are least, well evolved. So this is about growing the presence of the academic partner on all the sites to impact patient outcomes through innovation. And we have a couple of examples. This is the digital lab at Tullamore University. And then we have, of course, good examples up around St. James's and the Guinness Enterprise Centre. And of course, with down to Trinity East and all the way out to the hospitals, but mainly to the COOM and to St. James's. And these are some of the examples of what we can do. These would be medical devices that have come up out of the university and spun out into the hospitals. We also have, of course, the other side of the coin, which is HI, which is out in Tala, and looking outwards on that access all the way out to Tullamore and Mullingar. But what we have here is a lot of empty space, and we haven't really worked out all of the assets that we have in that area. I'm not a great fan of doing too much mapping, but this is the one area where I think we probably need to do a bit of a mapping to understand our physical assets and our IP assets, our economic assets, and our network. So where indeed does this integrated relationship get articulated? Well, in health charity partnerships, in public processes, in requirements for designation, in European funding, in health research strategy, in national policy. The question is, do we articulate it enough internally? Do we have enough internal buy-in? So the world outside sees it coming, but I'm not sure that we've fully caught up with that. So hopefully in this next iteration, the point of this role will be to help build that out a bit. And the hope is that the university, through its faculty and school, will be the glue that binds everything, but that the CCAO role, working with the university leadership and working with the group CAO, will form a powerful triumvirate that will help us achieve the aims. So how will we know it works? And we're just at the end of this. This is the HRB impact framework. I'm not sure that I would certainly be able to address all of these things, but there may be things in there that are very important, and we'll all have different priorities, I expect. But some of the most important for me will be the collaborations, partnerships and networks, and informing policy and the public about what we do. So as the cat said to Alice, the direction of travel doesn't matter all that much unless you actually know where you want to go. And I think we're in the process of deciding where we want to go. There's a lot of flux and evolution in the system, and it isn't an easy journey that we're facing into either. It'll be quite hazardous in its own way. We won't get a lot maybe of validation along the way, but there is success at the end of it, and we have to keep our eye on the long game and plan for a long future. And having worked with you in partnership across education and research for quite some time now, I would say that the university and its group are at a very unique time point. The institutions that we have reached a level of maturity, and I hope that we're at the right group, right time, opportunity. We're a very small country on the edge of the world, and our best chance of really being successful and being impactful is to work together and gather the strength of cohesion. So the differentiators for this group in the future will be its breadth, its depth, its quality, and its ambition to deliver a vision and unity of purpose that recognises that what we can do together to be a showcase for Irish healthcare. They say being strategic is about being focused in the leadership. And this first 100 days of this post, I hope to be mainly listening and analysing the challenges and the priorities that each of the disciplines within the school has and that the clinical partners have. And I've started that journey by going out to visit Naas and Tullamore, and Portlaoise is coming next. Obviously to go out and that takes a long time to go through places like Tala and James's because they have such a lot, and also to start the business of meeting all of you. So I hope an effective CCAO at the end of it will bring us together in I don't know what you want to call it, but some form of academic health science convergence. I don't call it a centre or a system. I just think it's what we do together to really improve patient care and to inform policy. So I'm going to leave it at that. I hope I haven't gone on too long.
No, not at all, Martina. Thanks. Catch your breath there. No, well done. That was a great tour around the not just the acronyms, but a bit of the landscape, maps, everything. So no, there's and you covered a lot of ground there. And I'm sure there are a lot of questions. We've quite a bit of interest in this, not surprisingly. I think it's timely and it's important for everyone. So what I'm going to do, if that's okay, is we have 3 or 4 pre-submitted questions, and I'm going to ask you to comment on those first, some of which you may have touched on a little bit already, but I think you might want to just see if there's anything you want to add. Then I'll ask the panel. We have some people, as it were, in the room. Mary, you can see Mary and Colin there, if they have any reactions or questions, and then I'll throw it open to the audience, who can either choose to submit a written question, or if they would prefer to do it verbally, there may be a way we can organize that either. Is that okay?
Yeah. Sure.
Great. So I have a question from Sarah Burke. Given the policy direction and the plan to replace hospital groups and CHOs with regional health areas, what is the role of the Chief Academic Officer in the new regional structure?
I don't think it's clear yet exactly. So at the moment, there seems to be a template which looks more at education and training than it does at research and links with academia. But nonetheless, it's a start. So that's the first site we've seen of the role of the Chief Academic Officer in that mix. We would hope that they will end up in the strategic management team of the RHA under the direction of the RHA Group CEO, which will have a team that deals both with the community aspects and also the hospital aspects. And I outlined there in one of the slides the 3 or 4 different areas that person has to deal with. Some of it is operational, some of it is governance. There'll be bits of it that are related to the delivery of clinical services, and in there is clinical and academic research. So that's as much as we know. Still haven't, I think some funding should probably funnel through that way eventually, but how much is undecided. I am aware of one costing exercise that is going on. I think it would be very important that costing exercise, if it ever becomes the template that's going to be used, would be very fulsome and also future facing.
I hope so, because I think one of the things we touched on previously is the role of research embedded in the structure, and I know you weren't like overly optimistic about how well that's mentioned, but let me get on to the next question. How might the academic officer for Dublin Midlands Hospital Group and potentially RHAB propose to retain or secure prioritized clinical placements and support structures for our student body in an evolving health professional education market? For example, in nursing, where there will be competing demands for placements and on the clinical support role from other third level institutions. So I suppose that competitive piece that we're in.
And we are. And do you know, it's competitive and it's not competitive. So it's not, we don't worry about the competition as long as we're able to differentiate our own offering and the quality of our own offering. So I think, you know, the work, it stands in its own merits always. So if you have a quality offering, it will draw people to that. But clinical placements is certainly something that requires a more national approach that has been lacking, I would say. It hasn't been joined up. We each of us go and advocate for our own clinical placements in our own way, based on the systems that we've got, but we don't advocate at a national level. And it's not even clear who exactly at a national level is the one that's holding the cards for us. So if you go, sometimes if you go to the HSE, they tell you it's the HEA. The HEA might tell you it's the Department of Health, and you tend to go around in a loop. And clinical placements can't really be divorced, I think, from physical infrastructure, because once students are on the ground, they need to have facilities, and neither can it be divorced from those who look after the student in the placement, no matter what kind of student they are. Some places, I mean, I think nursing have got this very right in terms of the clinical practice facilitator role, medicine less so. So we tend to operate on the basis of a more transient group, which are lecturer registrars. Probably there are aspects of both that could be brought together. So one of the advantages of the clinical lecturer role has been its mobility that sometimes tends to be lacking in the clinical facilitator role, so that they don't necessarily move with the student. So they may be site dependent. So there's a lot of teasing out that and figuring out how you could integrate that package to bring forward something more sophisticated that works for us and also for the student, but primarily for the student, because it's in our interest that the graduate is really competent, and not just competent, but really invested and engaged in working on the site. So the beauty of the nursing approach, where students stay with the principal site for a long period of time, allows a great relationship to build up. But on the other hand, there are aspects of the medical sort of model of moving people around that gives them a breadth of experience, you know. So I think we need to work a lot more together in understanding the positive aspects of the challenges for each of us, so that we can bring forward something new, because I think it's going to take something new.
Yep, for sure, to break the deadlock. Yeah.
Yeah.
Just two more questions. Could you comment on the strategic academic priorities and alignment, so academic priorities and alignment of Dublin Midlands Hospital Group and the other TCD academic partners? How will those align with the Trinity Academic Medical Centre recently proposed at St. James's Hospital? And you mentioned that briefly, I suppose, there in your talk.
Well, the first thing to say is that this whole concept of an academic health sciences centre is very much on our eye line, but it's not really in the eye line of government, you know. So I think the RHA structure is taking precedence right now. That's all really about the community. And in terms of the academic thinking around that, it's all really about training and health services research and service improvement. So that's going to be first. So I think in a way, whatever we formulate or frame as the academic health sciences convergence, if you like, of the future, we need to start thinking about how we frame it in terms of how it looks from the perspective of the community and in terms of the delivery of service. So beyond that, then it's clear that we are very lucky that we have enormous capacities for really complex and innovative work in our main hospitals, and also we have a great collection of Model 3s and specialised units. So it's about seeing what we can deliver really at scale, but at real, you know, innovation. So what can be really different? And I think we've started that recognition of what happens when you bring the whole together, what you can do in the cancer space, for example. You know, getting an internationally benchmarked accreditation, for example, for the Cancer Institute is very important, and how that teaches us to transfer that kind of thinking to other disciplines. So I know we will be very lucky with CHI, but what we probably haven't grown enough children's health and well-being into the research priorities of all of the partners across across the university. I think it'll be the same with women's health, and it might take 10 years before we have a hospital, perhaps on the James's campus or elsewhere, that is a women's hospital. But we have to start growing now our thinking about developing the research profile of that. I mean, we've clearly done a very good job in terms of aging and intellectual disability, and to some extent neuroscience and academic psychiatry. But again, I think there's much more that could be done with the concepts around the mental health of our communities, and bridging that out to inclusion and diversity. So these are things we have an idea about, but we haven't formed them up really. And I think they're things that the clinical partners really want to also be able to join with us to do. I don't know if that really answers all of the question, probably answers about a tenth of it.
Yeah, no, I should say, no, I think it does, because you know, it's something we're going to have to come back to, I think, as a faculty as well, is when we talk about an academic health science something, what exactly that is, because it does mean slightly different things to different people, and it's probably an evolving concept. But
I will say though, I tend to think of it very simply as a more realized version of integration. So when you look across what we've got and you think of where the integration is really excellent, that's approaching the model we want. I don't think it's about having 6 8-story blocks or X number of professors. It's really about believing that when you deliver research, that it actually impacts patient outcomes, and that you're seamlessly moving forward together on that journey with your clinical partners. So it's quite conceptual.
And including education in that, I suppose. The last question I had before I turn to the panel that was brought in, and you kind of touched actually a little bit on it there when you mentioned women's health. Thank you for the presentation. Would it be possible, please, to refer to the School of Nursing and Midwifery to be inclusive of our midwifery students who may be listening in? And I guess that touches on, you know, your remit is a broad remit, you know, not just obviously nursing, midwifery, you mentioned medicine and pharmacy, but of course there's therapies as well involved, and possibly new healthcare professionals of the future. This is both an opportunity and I suppose a little bit of a minefield for you to try to fit in, to see that the needs of everybody are being raised. At least they won't be met, but at least that are raised at the table. Is that something you're aware of? Or
I absolutely am, and you know, I hesitate just to be too specific in this, because obviously I'm coming to the table not knowing everything about any given group. So for example, I had a tutorial this morning from Finton about the various streams of nursing education that I really wasn't aware of, despite having been a nurse 1,000,000 years ago in the old apprenticeship model. I hadn't realized just how far things had changed and how much things had moved in terms of the different streams that you can come into. I do understand though that each of those streams raises a core of excellence that has to be addressed and managed and maintained, but at the same time, to some extent, probably produces some areas where there's duplication. And where you're perhaps fragmenting your resources. So, but I completely see the need to maintain the core quality of any particular one of those disciplines, be it mental health, nursing, intellectual disability, whether it's general nursing with children's, without children's, or whether it's midwifery, and midwifery being its own profession in its own right, almost, or almost completely, you know, a different stream. So I would hesitate to have too much commentary on that, because I don't feel fully informed yet. But you can be sure when I've had the right number of tutorials, I will have something to say about it in terms of helping if I can.
I think that's something we have to give you some chance to kind of get a full grasp of. No, thank you for that, Martine, and you can maybe have a chance to pause there again. Mary, I'm going to turn to you, and then Colin. But in the meantime, if anybody from the webinar audience have any comments or questions they want to put in the chat, now is the time to do it. So Mary, you've been listening to all of that. Do you have any questions or reaction there for Martina?
Great. Yeah, thanks a million, Martina. It was really fantastic presentation, and nobody could doubt the breadth of the job of work ahead of you. You know, it's really massive undertaking to take in everybody within the faculty and try and drive the group forward. But I think one of the things that's probably common amongst us all is this clinical academic research pathway. So what's your vision for that, or how do you think that there's going to be integration, or is this going to be very profession specific, or how do you see that mapping out in the future?
I think it's going to be quite customized. So I mean, I think we have a model that has served us well enough, you know, with the clinical academic 50-50 type post, but it's very top down. So we have a lot of clinical academics that are up at the professorial level, and we don't necessarily see that drift down. So the lecturer registrar level is not tenured, it's very inconsistent and unstable. And so we've learned a lot from that we would suggest you, we've made mistakes there, you know, for certain, that maybe others don't have to make. On the other hand, when you look at, say, nursing in particular, I would say you haven't maybe picked out exactly at what level you want that to work best at. And it's, you know, if you create it and it's too clinical, it won't have the capacity to teach and research. If you create it in a way that's perhaps too academic, it may not deliver what you need on the clinical sites in terms of credibility going forward. So that's why I think there's a huge body of work to be done there, and then to try and go out and sell that idea and work out who's going to pay for it is another thing entirely. But I think there is a need, and I think the clinical sites and the clinical partners recognize that the relationship around that has become unbalanced, you know, in terms of who's delivering the teaching and training on the ground, and who might be able to contribute to the research in the future. So I think it's certainly going to be a journey we'll go on together. The clinical partners will be involved, but I would hope that the university and the academic partner will lead that to show a way and to show some flexibility, perhaps changing from what has been our established norms into something that is more future proofed, you know, with a degree of transferability between the two. So in people's career pathway, you know, it used to be the same thing forever, and after 40 years you got out, but now it has several phases, you know, and people want something different as they come into that later phase, and they want something different when they come out of the first phase and into clinical practice. So it's a complex enough matrix. I have some experience of developing clinical academic pathways from the earliest stage of training through the academic internship program and ICAT. And I can tell you one thing, I don't know whether it's a helpful thing to know or not, but when you unlock someone's personal potential and they feel they're really making a contribution, you retain them. And they want to do their best for the patient. They want to do their best for the university. So it needs to be something that is embracing, you know, and nurturing of the graduate. And I think if we don't get them early into that mindset, then they're lost to you for a very long time. And sometimes when they come back much later, it's less productive for them, and less productive for you, and less satisfying for them. So I would say we need to start at the very earliest stage of training.
Yeah, I totally agree. I think, you know, recruiting them is one thing, but retaining them is a huge challenge in itself.
And succession planning.
Yeah,
we're all getting old. No, you're not getting old. I can find that to my quadrant of
not at all. Thanks. Well,
right. Is that it, Mary? Are you okay with that? Great, thank you. And Colin, you've been listening to this. It's you're probably, you know, it deeply concerns you and your school as well. So I just wonder, is there anything you wanted to raise or discuss at this point?
Well, I mean, Martina and I go way back. We're getting older together, Martina. I'll just say the word older. Maybe I'll just nuance some of the things rather than ask you a question, because I think we talk a lot. maybe just nuance some of the things that have come up. So I think the two things that I'd like to mention that are future challenges and not clearly, the route forward is not clearly evident yet. The first is the, as you say, the health professional of the future. I think we all know that person's going to be relying heavily on interprofessional practice. And we're not doing interprofessional learning enough to make people ready for interprofessional practice. And that to me is something that we really need to address. And I do think that there's a recognition of that across the faculty, which is great. Faculty works closely together. As you know, the School of Medicine has a whole lot of therapies and scientists who are undergraduates in human health and disease. So we have lots of opportunity to do that, but it just needs to be formalized. And how do we, and then if we do decide to use interprofessional learning together, where are we going to do that? Where are we going to, what kind of spaces are we going to do that? Is it going to be small group interprofessional learning? Are we going to try and get everyone together? There are things which, you know, like self-care and professionalism that could be taught to everybody all together. And then we obviously need to work in teams and simulation. Simulation is absolutely something that we are behind the School of Nursing in, and we need to do that. And then the second, and maybe Martina might want to just comment on those. The second thing that I think is really important, and Martina said it several times in her presentation, which is the idea that, you know, the biggest issue for us in research terms is making research findings relevant to patient care. Now, you know, that's easy to say. It's easy to say that, but I'm sure somebody who works, say, on, and I'm thinking of specific people that I know of recently who are working on stem cell therapy for Parkinson's disease, for instance, are going, oh my God, when is my stem cell therapy going to be relevant to patient care? Versus somebody who works, say, at implementation science level in implementing care pathways, where you clearly want to get that rapidly into implementation for changing a pathway. And I think the answer there is that we have to be inclusive. What we know is, what I feel strongly is that we want to move the researchers to be working with the clinicians where the disease process is being treated. Mm-hmm. And if you like, the whole idea of the cancer center, for instance, is to bring the researchers and the clinicians and the patients together on one site. And I think that should be the model we're looking for, that we want to bring everybody together, you know, so that they're working together. So even if it's very early phase, basic science, you know, that person is still feeling part of the project, if you like, you know what I mean? And it doesn't have to be that we're all now become implementation scientists. Do you know what I mean? Hmm. So that's just something maybe that we need to think about. And I suppose broadly speaking, I always ask this question is, what is it about, you know, will we be ever like Johns Hopkins? Will we be ever like Cambridge, you know? And we're a small country. In terms of the numbers we have, we'd need to be operating much more at an intervarsity level than they do. And actually, I think we could do that. I think we could do a lot more of that. We could be the, you know, I mean, obviously for reasons of distance, you know, collaborating with Galway and Cork is less easy than saying that there's a Dublin collective, you know what I mean, of academics and teachers that could be working more across the universities. I'd love to see more of that. And also maybe something particular to Trinity and its research ethos, which was delivering care to vulnerable populations. Mm-hmm. I would love to think that somebody said, well, where in the world will I go that delivers care to the most vulnerable? And somebody might say, well, Trinity College is the place to go and do that. And I think that's something that we have always done. And it's something I think that we should promote as being an ethos of ours, that we should own that. You know, like Johns Hopkins has a building where they treat the Saudi royal family, you know, only. We're never going to do that. We're never going to have a building where we treat a rich person who gives us money. So do you know what I mean? We need to be the place that people say, if you want to treat the poorest of the poor, you need to go to Trinity, James's, Tala, and our other sites in Dublin, Mid-Leinster. And looking at the group, there is such a huge potential if we were all to have a cohesive vision like that. Such a huge potential for us to deliver great care. And I'm very excited about it. I think all the maneuvering between groups and regional health authorities and all those things, I mean, they're constantly happening. If you work in the health service long enough, you'll have been through 6 different changes at the top. And ultimately, still at the bottom, the need to actually deliver the service to the patients is always the primary goal. So Anyway, I don't know, Martina, there's a lot there, but whether you want to just maybe pick out one or two things.
Yeah, I happened to be down in the Coombe the other day, and I was trying to explain the fact that we would never have a York Street, you know, the RCSI amazing simulation center, and you know, because we just won't. I don't think we could afford it because we're a public university with primarily public hospitals, so I don't think we would. But we managed to convince ourselves that perhaps we had dodged a bullet by not having York Street, and how lucky we were that we weren't going to have this amazing building, because it meant that what we would end up doing really was bringing ourselves into the workplace. And maybe what we're looking to do is, yes, we will have simulation to a point, but simulation that remains just as observation and doesn't translate into the workplace is probably ultimately not where we want to go. So it may be that we will become the flagship for point of care simulation, for example. And within that, the flagship for interprofessional learning. Now, I think, you know, we think we haven't done very much, but actually as a faculty, you've done quite a bit. And there's been the Cohere project, which has looked fundamentally at the development of the professional identity of the healthcare practitioner across all of us, and what the challenges for that individual are, and how they self-determine, how they are motivated, what keeps them engaged, and how they are remediated when they run into trouble. And it's been a very successful collaboration, and we find mostly that there is less difference between us than there is commonality in terms of understanding how somebody develops as a professional, and what motivates them to keep going. So I don't have any fear for our ability to find common ground. I think we do have to decide, though, where we're going to place those individuals so that they are most clearly seen and get the value of their work. And I think it's probably not in a classroom distant from the hospital. So I think it needs to happen close and proximal to clinical care. That is our place of relevance, and it's where we have to fight our battles, I think, really. You know, such battles as they are, and there's not too many of them. In terms of the bringing the value to the patient, I think it's about asking ourselves, what is of value to a patient now? I mean, they have a lot of information, they have plenty of places to go. What they need is somebody to help them negotiate all the information, not hand them an optional list of 10 different things that can happen to them, but help guide them through it. And that's common to all of the professions that we have. If you are a very well-informed, intelligent healthcare professional with extremely strong ethical basis for your practice and great deal of integrity, you will guide a patient through whatever your discipline is, whatever your specialty is, and whatever your level is, to something that is, if not a great ending, or maybe doesn't always have a great outcome, it should always be an empathic experience for the patient when they come in contact with our healthcare professionals. And this, again, we have a very long history to draw on. We've got a lot of examples, narrative and research-based, that we can draw on to inform the ethos of care that's delivered by this academic partner and across these hospitals. And all of that is in the public eye, and that's where we're going to live it out. So I don't think we'll ever be a Johns Hopkins. We might be a Cambridge, though. I don't see that as being too far away. And if we're not a Cambridge, we might be a Manchester, you know, very much living in the middle of our city. And living in the middle of our group, and extending out into the prevention aspects of inclusivity that we haven't really touched on. So when I started in St. James's, you know, there was a lot of drugs in the area. Things have moved on now, that's much less the case, but there's still a lot of health prevention that has to happen among those populations, and this would be somewhere I would think we should be able to make quite an impact.
Great. Yeah, thanks, Martina. As I say, we're really covering a lot of ground here. I just wonder, to zoom out a tiny bit even more, you are one of a group of chief academic officers from around the country, and I know you meet together regularly and discuss a lot of these issues. What are the issues that you think there's commonality around the country in the different groups or what they will become regions, and that you think that working together, you know, we have a chance of realizing versus maybe some of the things that are particular to our parish?
Well, look, there's some low-hanging fruit that's of value to everybody. So things like biobanking strategies and, you know, sort of particular research programs that work. So, you know, that they will have a common view on, that are not in any way conflicted. So in other words, people aren't going for ground. So it's in everyone's interest that there's a national biobanking strategy. It's in everyone's interest that there's a national genomic strategy, for example, and that all of the various players and disciplines that should be involved in that are involved in it from the very beginning, rather than it being a top-down approach, or rather than it being a particularly discipline-centric approach. So some disciplines, some things have been traditionally very medically based, you know, and the other professions haven't necessarily come into play until too late for them to be able to make an impact. So the first thing I would say is the chief academic officers need to take a very clear-eyed approach to the multiplicity of disciplines that fall within their remit, and to work across disciplines. So we try to always ask the questions, what other disciplines would be involved? Is it nursing? Is it physio? Is it pharmacy? Or is it some other, like the radiation therapists, for example? And then to look for opportunities for those groups. So they are quite good at that. And also in terms of raising the awareness that there needs to be an academic life within every RHA, there needs to be an academic life within every group, and that academic life needs to be articulated at every level and across every discipline in order to provide the right patient outcomes, to improve patient outcomes, and to influence policy. It's a very clear and simple message. And in a way, sometimes the academic officers can write as a group, which I think is very helpful, because it means there's a second group coming in. So for example, if the pharmacy board or the nursing board are worrying about placements, it adds extra weight to add the voice of the chief academic officers. And by the nature of the way the posts are pivoted, they have access both to the CEOs of the hospitals and the CEO of the group, to the general managers, but also to academia. So this is the nexus that I think that group has to try and work at, to try and see it from multiple different sides and help people to find a way through. I'm not sure what we're going to end up exactly doing, or how you'll know it was a success. Maybe the skill that we don't have, or I don't have, that I might need, is either planning or counseling. I'm not entirely sure. It might be somewhere in between, but you know, that's the area that I see that they can work, is to bridge the gaps and bridge the space between the clinical partner and academia.
Yeah, thank you. I mean, there must be a lot of commonality, I'm sure, you know, around the country, and most of the things we've spoken about. Maybe they're more or less a priority in different places, but you know, that's it. There's just one other question come in, Martina, so we might let you have a bat at that, and then maybe give you wrap it up if we have no more concerns. And it's about PPI. PPI is a very healthy process in which all aspects of our work. What plans are foreseen to further formalize PPI involvement and to use this input to deliver on our strategies?
Well, I think the PPI Ignite process has been a revolutionary for all of us, to be able to see things, and having groups like Michael Foley and Sarah Barry engage at the Trinity level have been really, really helpful. And they you know, I think IPOSI are obviously a natural leader to us here, and to inform our thinking. I don't think that, quite honestly, at the RHA level, I haven't seen any evidence that there's any formalized processes yet, right? So I don't think it's reached that level of maturity. But there are, but it would be important, I think, for the group to develop its strategy around that, to inform the RHA, because I don't think that the RHA has it. I don't even think the group has it. There are great pockets of excellence, but they haven't been brought together. We have patient representative groups, of course, on the different sites, but they don't necessarily work together. And the best places I've seen it work is in the co-design of services. So when you have a very strong national group, for example, I'm thinking here of my own experience with the haemophilia group, They really inform excellence, and they're very I think very nuanced in understanding that, you know, the most basic molecular research, they don't necessarily need to know, they don't want to be down spinning the centrifuge, but they want to understand how it might inform the future for themselves so that they can go out and inform other people. And that's where, that's, I think, where it comes into play. But I haven't seen a formalized strategy. If it's something that becomes a priority for this role, I certainly would have a good idea of where to go to link up the pieces, but it's certainly something I'd need help with.
Yes, and I think, as you say, ironically, something that actually the university at this point is probably better at than the health service, which it should really be the other way around. But you know, that's great that we can, maybe there's things both sides will bring to the table, and that's certainly one of them. So
partly
no,
the reason, one of the reasons why we have maybe gone out ahead there is because the funder is demanding it.
Yes,
so
exactly.
so many different groups are demanding that level of integration that
you
know.
That's a good point. Yeah, good. Well, look, as they say, we have a lot of thanks coming in, and a lot of appreciation for your talk. A lot of people very excited about this, very complimentary, Martina, and thanking you for coming on, and you know, really enjoying, you know, your presentation and the answering the questions. So yeah.
I'll do my best not to let you down anyway.
Yeah. Now you have an audience. You're practically an influencer now at this stage.
That's it. I shall have and for somebody with a zero no social media profile whatsoever, I shall have to learn the art of the tweet.
Yeah. Well, I'm not sure if Twitter is politically acceptable these days or not, but as usual, you'll find your own way of doing it.
Yeah.
But thanks again. Exactly. I'm sure we haven't seen the last of these presentations, like judging by the amount of interest, the number of people who've stayed in and stayed till the end, and the questions and the comments. I can see this has actually been really of interest to people across all the schools. So we will revisit again. You know, we'll talk about that maybe when we have something that needs further discussion, or we want further input. But once again, to thank our panelists, Mary and Colin, for the discussion, and everybody else who stayed with us, Lena, of course, for organizing. And thank you. Enjoy the rest of your day.
Thanks a lot. Bye.
Thanks. Take care. Bye.
Thanks, everyone.